We're in the most scary time in healthcare in my career, and most of the people here as well. The transition. Now we're going to be asked to do a lot more with less over time and have safety and improved outcomes for our patients. So it's a perfect storm. It seems like how can you possibly do that? And the answer is we can, but we have to think differently about the way we deliver care. And the traditional model of healthcare is delivered by a physician and a patient only is going to have to be given up and get expanded way to think about care delivery. So a lot of what I'm going to be talking about is exactly that. So there we go. So the first thing I want to have a disclaimer, and I started two companies of which I own partially, and Angel Eye, which we'll be talking about in this discussion, and Aratogo is another company that really is not pertinent to this discussion, but I am part owner. So there are some economic benefits and spin-offs that happen as a result of innovations. Okay, the most important thing I'm going to say today is that healthcare in the last 2 decades has kind of lost its soul because we stopped putting the patient first. You know, that's the mistake we made. And we thought too much about running a business. And as a result of that, we lost our way. And while you have to be revenue neutral and pay the bills, ultimately, if we lose sight of our consumer, then that's a big mistake. And I think what we're going to have to do is get back to the patient and put the patient first in everything we think about. At UAMS, we're including patients in all of our decision making. I have a departmental OB/GYN meeting. I include patients in that meeting, actually sitting in the meeting. They come to our faculty meetings, and we want input from them. And we do things because we've done things without including patients in our decision making, and it's gotten us in real trouble. So, like I said, it's a great change. We've got to increase production, cut production costs, and improve safety simultaneously. And that's hard, but remember that it's not a factory, it's about the patient, right? So that's what we need to stay focused on. And so, the Rural Healthcare Act in Arkansas is our state just recently, in the last month, decided to take this. And this is the RAND Corporation who was contracted to look at the impact on this program on our state. And one of the things that we have is that we have 40,000 new patients by 2016, and there'll be 190,000 on Medicaid, 210,000 in insurance exchanges. And this results in a plus $67 billion reduction in uninsured patients. At UAMS, our school was reaching up to 13% admission to the hospital of uninsured patients. And so, left without some kind of change, if we continue to see uninsured patients, either the hospital goes out of business, which would be bad, or we stop seeing these patients without any kind of change, in which case people die. Those are the two choices. So, and I don't think we say that enough, but it's either let patients die. You know, we can't cost shift anymore. So we would say, okay, this patient doesn't have insurance, we'll charge the next two twice as much, we'll make the difference. Insurance companies can't afford that anymore. So we're in a situation now where either we don't admit these people and let them die, or we have to come up with some way to pay them. And I wish that in the national debate somebody would have said that more frequently. And even after this, there'll still be 170,000, 150,000 uninsured for various reasons out of that 470,000. And one of the big things is the Medicaid eligible have to be enrolled. So if we fail to enroll Medicaid patients, we're going to be in much worse shape. And this is no small process, by the way. So that's going to be one of the challenges for this change. And as a result of this, Arkansas stands to have $430 million net over the next 10 years, $750 million for Medicaid, and $850 million for exchanges, and they're going to lose $118 billion of state money due to new taxes and to Medicaid cuts. But that we still taking the money, we get $430 million. The economic effects of this would be 6,200 new jobs, and without Medicaid expansion, we'll lose $330 million because we still take the new taxes and the Medicaid payment cuts. So it was a kind of, should have been a no-brainer that you could make $430,000 or lose $330 million, which would you choose to do? So that's kind of the estimates. Now that's contingent on things working out. Now, so again, we have to provide care across the healthcare continuum. We're at a teaching university, the only medical school in the state of Arkansas, and so we have a wide range of specialists across the school, many of which aren't available in other parts of the state. In my particular specialty, there are 4 MFMs, 5 MFMs in the state of Arkansas, and so I'm not there now. So I've just reached 20% access to MFMs in the state of Arkansas by leaving the state. And MFMs. Yeah, maternal fetal medicine, that's a specialist in high-risk OB. So it's additional 3 years of training after OB/GYN residency and training to take care of sick mothers and sick fetuses. So there's a shortage of MFMs around the nation. So that's one of the reasons we started the program. And so, when Albert Einstein said insanity is doing the same thing over and over again and expecting a different result. So if we have 5 MFMs, how do you provide care up, say, Arkansas? We can't travel to every little town, particularly since it's 4 hours, 3-4 hours in some areas. So we had to come up with a new way of providing care support to high-risk pregnancy. And so, the concept of using distance health came up. And so I'm going to show this slide. Uh-oh. Is it playing? Yeah. We have hospitals and physicians unless there's a reason to that, and to try to back transport as much as possible. And so, if you look at the medically underserved areas in Arkansas, 73 of 75 counties are designated medically underserved. Some of these counties do not even have physicians in the counties or any healthcare providers. And so, it's a really bad in terms of the support in rural areas. You go up and down the Delta, this is a very, very poor area of the nation, and no jobs and a lot of huge problems. And so that's the thing we're facing in Arkansas. So there's this healthcare disparity in which you have where you live does determine whether you live or die. And I think technology, for the sake of technology, is not a really good solution, but technology, when applied to a problem, is how we gain from it. So, inventing stuff and then figuring out what the hell we're going to do with it later on is not so good. It's better to have a problem and say, here's the problem. How do we use technology to solve this in an innovative way? And that's where you get the big bang for us. So this is a single cell. You can take cells out of tissue and put it in a level with our license. And I'll say in the Angels program we use even EMTs in part of the phone center that we use to help triage patients. So, but in a regulated fashion, so that they function within the boundaries of what's allowed by their license and their training. And so that's why we have to think. So there's going to be increased production, increased profit, increased money. So the only way to respond to that in a business sense is to reduce your production costs and hopefully increase the amount of production that you have to maintain revenue neutral status. That's one of the most important things I'm going to say is that in order to respond to reduction in payments, the only alternative is to do this. Or, if you cut production too much, what happens is, you cut nurses, you cut, systems, and that's not good. Particularly when you have more. So we use these broadband lines as the nervous system, and we provide equipment to the rural areas, the rural clinics and hospitals, and then we support this network 24/7. And this is just we supply the equipment and the T1 line to these areas, and if they need additional equipment, we either let them buy or we purchase equipment for them, like electronic stethoscope. We're doing some stuff in prisons now where we provide a lot of equipment that the prisons need to be able to do it. If it makes fiscal sense, it's not part of the grant, it makes fiscal sense, we'll do that because we can recover the cost of the equipment. Also, we made the decision that we wanted everybody to use our equipment, so we purchased the same equipment, and our IT people troubleshoot the equipment more efficiently than if everybody had every other kind of equipment. So we maintain central control, which I think has been a good choice ultimately, because we can actually fix the problems when they occur. One thing healthcare providers don't want is failure of equipment. They get very frustrated real fast and they'll quit using it. Doctors are like little babies. You have to mess with them and tend to them a lot. So we also do education, archive, live streaming, and interactive education. Interactive education is the best way to educate people, by the way. There's a lot of data that passive learning really doesn't work. So having interactions with providers, asking them questions, getting them engaged, then they get more on-the-job kind of training. And then we deliver healthcare by teleeducation, which I believe is very much a part of healthcare delivery. Teleconsultation with the provider, and then telepractice. The Angels program is telepractice. We're actually delivering care to the patient over interactive video without their local physician present for the consult. So that's a little bit different than if you're just doing consults with the provider. And then teleresearch, which looks at do these things work, and even recruitment of patients from the rural areas using this network. And then I'm going to show you actual Angels high-risk OB consult. There'll be a genetic counselor that will come on to this as well. And the genetic counselors don't have to be in the same room with the doctor. In fact, one of our genetic counselors lives with the species that survived or the most intelligent survived, but is the one that is most adaptable to change. So I would argue that we're in a state change right now, and so if we want to survive, we must learn how to adapt to providing health care in a new way. And so how do you get started? So we started in Arkansas with the Angels concept, and then we engaged the lobbyists, internal government people in the school to work with government and Medicaid. So we worked both with these two groups that then helped us to engage hospital administration, the governor's office, public welfare, and then medical society and the hospital association and the state health department to help get things started. And so these are all the groups that were involved at different levels to be able to work with us, and even with congressional delegations. The congressmen liked very much the idea that they had earmark money. They could go to the school and ask the school to spend money in their district by putting equipment in their region. So it looked good that they'd spend the money on their people by putting the telemedicine equipment in their region. So you got brownie points. And so you've got to begin to illustrate cost effectiveness. The whole is more than the sum of its parts. Aristotle said that. So healthcare is a complicated system with 815,000 doctors, 3,000 hospitals, 72 billion admissions, 3.8 billion prescriptions, 208. It's now 18% of GDP. Healthcare is a big elephant where each of us understand parts of it. Doctors understand parts, nurses understand parts, healthcare providers, payers understand parts, administrators, but no one understands the whole big process. That's apparent to me when we started trying to do process improvement on labor delivery. No one understood why we couldn't get C-sections consistently in less than, in a scheduled time. Because everybody owned a part of it, nobody understood the whole thing. The only way to solve the problem is look at the whole process. Factors drive healthcare is not just the hospitals and doctors, but it's also the patients and the insurance providers and the healthcare, we talk about healthcare providers. So it's the patients also involved in this. They're not really held accountable for their actions to any degree. And I think as we begin to move forward, the patients are going to have some part in this whole process as well. And so you don't always get what you pay for in anything, but expect to get more when you pay for it. So that's the problem with healthcare, like I said before. So in places they cut the amount of money they pay for x-rays to doctors, and they found out that often the doctors would double the amount of x-rays they order and they maintain their same profitability. So you fundamentally have to really kind of research the way you pay. One of the big things that we did was a triage call center, got us out very early in the process, and through this we were able to facilitate patient transfer, keep people out of the emergency room by doing consults with nurses and the patients, and we communicated effectively with healthcare providers. So we created an intelligent boundary interface between the patients, the doctors and hospitals referring to us, and the system internally. Before that, there wasn't exactly a good interface. And so I can't stress the importance of that, because you need to be able to have a point of contact that's consistent, manageably, and have rules that are implemented. And the call center has been hugely beneficial in managing this. So when you have the payment system, if you look at what happens in the payment system, the healthcare provider and the hospital are paid differently in a siloed approach. So that what the provider does impacts on the hospital, but it doesn't impact on his payment structure. So if I order extra tests than are needed, it affects the hospital, but doesn't affect me. So why would I order extra tests if I was worried about something? So until you begin to link the two systems in some way, you're never going to see the doctors really highly integrated in what happens on the hospital side. And the hospital side is where all the money's spent, truthfully. And so as we begin to do this integrated care network, it allows more patients to remain in their community. Community receives the market share of the resources, and it meets the psychosocial needs of the patient in their home. And allows the provider to learn from the exposure to the care delivery in their area. So I think that's very innovative. Not enough is discussed about keeping the providers linked into the care delivery system. They tend to lose their cutting edge care delivery in the rural areas, and they all fear for this. And so by having this connected network, I think it can keep these guys much more current. I've personally told patients that their baby, their fetus is going to die over the interactive video, and they have said they like to hear the information. We've done surveys. They like to hear their information in the rural area near their home rather than the big city away from all their support.